That's right. And then, as I said, one other important sequence is really to test and treat the cervical spine first, irrespective of whether the patient has a cervical. The
Irrespective
number
of the complaint, but not
is
irrespective of, I mean, you're screening the cervical spine, finding something,
that's right.
and irrespective of symptom, a painful symptom.
Irrespective of symptom display, you
Yeah,
must seek to find out if the cervical spine is free of problems,
yeah.
because the progression of symptoms from the cervical spine can go all the way down the body and affect areas of far distal from the cervical spine, and they don't necessarily mean that there are cord signs to
Yeah.
to indicate that this is the case.
Okay.
So yes,
So we
so
were
the
talking
cervical
about
spine
yeah,
should
cervical
be
spine.
treated first. I've had several patients where, on treating the cervical spine, so much was restored to the rest of the body. A return of function, balance, ability, range of motion in the lower extremities, strength in the lower extremities, decrease in symptoms in the lower extremities and upper, decrease in symptoms in the torso, improved neural tension,
You
decreased
sound
neural
like an upper
tension.
cervical chiropractor. Uh,
Oh,
I mean, all you got to do
there
is
is
adjust their
there
occiput,
is
put their
nothing new
occiput
on
back in place.
that's the mistake. Now that's not what I'm saying.
I know.
But it shows the primacy
Yeah.
of the cervical spine. It's how complex it is and how it is in its function and influence.
Yeah.
And so has been remarkable to do that because it cuts down on the work. It really does. It means that you do that and you reassess and you are surprised to find out how much better the patient might be. Now, if the treatment does not yield significant changes, so be it. At least you've
Right.
ruled it out, and now you can concentrate on the rest of the spine. But it is a mistake to read the information and not treat the cervical spine and start treating on the information you have.
So are you saying that essentially you are kind of treating, and I've used the term, and I think we've used it in the seminars, like we're that you are treating or desensitizing someone's cervical spine before treating the canister?
Yes, you
Okay.
should. You
Okay.
should,
Interesting.
because it can change all your baseline findings dramatically,
Hmm.
in which case the rest of your treatment becomes easier.
Yeah. Yeah.
Yes.
Okay.
So you do the baseline findings, you treat the cervical spine, you come back and you get a new baseline.
Interesting.
And then you continue. Because if you don't, you could be dealing with a lot of stuff that is really cervical.
Yeah, just white noise from the
It's just
cervical
white
spine.
noise from the cervical spine, and it can be far reaching. I mean, this lady could hardly do a single leg stance. She had weakness in the lower extremities. She had a palsy of the arms. She could not raise them
Dear
all the
God.
way. And her glute abductors, hip abductors, adductors, hip flexors were all weak.
Hmm.
But once I treated her neck, about 70% of everything was improved
Amazing.
significantly. I was shocked. She
Right.
was shocked. I was
I
shocked.
mean,
She was shocked. She's like, "What did you do?" I go, I wasn't expecting this."
yeah. I mean, again, it's like, you know, uh, I'm always thinking like, okay, if this was my patient sitting in front of me, what would I have done?
Mm-hmm.
And my if both lower extremity regional muscle tests are all weak, and she can't balance on on
Mm-hmm.
either leg. All
Mm-hmm.
I mean, my our the original thought would be, okay, well, core. I'm going to
Mm-hmm.
the pelvis and low back
Mm-hmm.
because that's where everything kind of stems from. But now
Mm-hmm.
I mean, it does make obvious sense to just go right up to the neck and the brain,
That's right. Get
because
closer to the brain.
yeah, get closer to the brain. Obviously, there's a lot of mechanoreceptors in the back of the neck and around the neck that can
Mm-hmm.
influence the brain and
Mm-hmm.
just general body function. So it does
That's right.
make sense. It's all there. I mean,
It's all
we just have
there.
to. It's
You
all there. We
just have to
get
read
to it.
it.
Yeah.
Yes. So that has been eye-opening. And then the other aspects that have been really interesting, again, when we look at areas of stress or compression, you have like the suboccipital area, you have the pec minor, you have the inguinal canal, you have areas around the knee with the popliteal space, and you have also the medial column of the foot, for example, um, the wrists and the tissue around the ankles. So again, looking at common symptoms, foot pain, the sensitivity of the foot, um, can be brought about, like metatarsalgia, for example, or plantar fasciitis, and you have a pseudo plantar fasciitis, a pseudo metatarsalgia coming from the plantar nerves being occluded. Uh, uh,
So you're
uh, uh,
talking. You said compression, which
yes,
compression, but you're also kind of lumping in kind of entrapment.
yes, that's right. So the medial column of the foot is under a lot of stress. So you have abductor hallucis, you have the quadratus plantae, you have the um, flexor hallucis muscles,
And the flexor.
you have all these muscles, and you have a lot of fascial tension. And sometimes it can start to occlude the plantar nerves, medial and lateral plantar nerves. And they can be caught and bound, and slowly they start to give um, um, foot pain. The patient has sore toes, metatarsals. Um, he can walk, or when it warms up, he's okay. But if he sits down and then he gets up, his feet are really sore, or they're sore the next morning and things like that. And I found that rarely, or you have a sural nerve entrapment in the tissues around the heel. So
Well,
it,
I mean, this is why Shacklock's stuff
that's
is
right,
so
is very
vital, important,
powerful.
fundamental. Yeah.
And it means that if you have these areas in mind, you are going to start seeing uh, how they are related or relatable to the presentation, and that even just by local fascial treatment, you can start to see a relationship that you can then exploit through Shacklock's work, through manual myofascial release, and so on. So that no one technique is necessarily the sole treatment approach for that.
Right.
For example, you have people who wake up with numbness in their arms after sleeping. And the entrapment could be at the scalena, it could be under the clavicle, it could be under the pec minor, for example. So just by releasing the pec minor, you can see changes in the range of motion and sensitivity of the upper extremity. And the patient reports that their arms are not falling asleep at night anymore. So now you can go deeper into it and suss out, like Shacklock, the nerve tests and all that to complete the treatment. But it starts to give you areas of things that you can tell the patient to start doing to help with the
Right.
treatment, self-help, and so on. So it is very exciting to keep in mind that these areas of stress are common to everybody. That tightness of the pec minor is quite a common phenomenon, especially because we are on our phones and having to adduct our arms much more often and for longer periods than we normally would have in the
And I mean,
past.
isn't I mean, am I wrong in thinking? I mean, the concept of pec minor tightness. Not only is it just a functional problem of, like you're saying, how we're using our arms every day, but it's any kind of cervical sensitivity, upper quarter sensitivity. That muscle is neurologically the one that will go into spasm
Yeah,
and get tender points
again,
and trigger points before the other muscles do. So it's
yes,
very sensitive to any kind of dysfunction,
yes. So
and
we
that's why
see
we check
again
it.
these, yeah, and we see these tendencies according to almost the Yanda classification of muscles tending to tightness as a
Tonic
dysfunction,
and
a
yeah.
dysfunction response. Yes. So those these kind of um, observations are clinically helpful and necessary. So it has been interesting to re- review the integration course to
If you enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook at IMTR Seminars.